Thank you for joining us for Talking Sleep, a podcast of the American Academy of Sleep Medicine. I'm your host, Dr. Seema Khosla, Medical Director of the North Dakota Center for Sleep in Fargo. Today's episode is sponsored by Apnea. There are currently 40 states with legalized medical marijuana. 24 of those have also legalized recreational marijuana. Many people report utilizing cannabis to help them initiate and maintain sleep. Is there any data to support this? Is cannabis safer than prescription sleep aids? What should we know about cannabis and sleep? Dr. Bhanu Kolla is a professor of psychiatry and psychology and a consultant in the Center for Sleep Medicine and the Division of Addiction Medicine at the Mayo Clinic in Rochester, Minnesota. He is here to discuss the impact of cannabis on sleep and its potential use to treat sleep disorders. Thanks for joining us today. Welcome.
Thanks for having me, Dr. Khosla. It's a pleasure.
As I was preparing for this, I was reviewing the data online on cannabis and sleep, and I saw that actually quite a lot of the information came from you. So I'm excited to get an update right from the source. And I will, I'm very transparent. So I will admit I have mixed opinions on this. So on one hand, I'm curious about potential new treatment options for our patients. But then on the other hand, it seems like dispensaries are popping up all over the place. And it seems like you can use this for just about anything, from glaucoma to anxiety to insomnia to chronic pain. So help me understand this better. So when we talk about cannabis, what are we referring to?
So it depends. There is the cannabis plant, the cannabis sativa, cannabis indica, but they have been interbred so much now that really the distinction is mostly academic. So these plants have compounds in them, and there are over 500 different kinds of compounds in the cannabis plant.
Oh, wow.
There are what are called phytocannabinoids, and there are roughly over 100 of these phytocannabinoids. And then there are all these other non-cannabinoid products like terpenes, alkaloids, phenolic compounds. The phytocannabinoids, the most common ones, the ones that have been most studied and most people are aware of, are the 9-delta THC, which is the psychoactive component in the cannabis plant, which people use recreationally to get high. And the other common ones are CBD or cannabidiol and cannabinol or CBN, and those are the common compounds.
Okay, I've heard, or I guess I've seen people refer to the 9-delta on Reddit when they talk about using it for sleep.
Yes, so they end up using 9-delta THC. Some compounds that people use contain CBD. There are some studies with CBN. So most people seem to gravitate towards the 9-delta THC, but the other compounds have also been used and studied.
How do I get this? So if I walk over to my dispensary, what are the products that are readily available?
So the first thing to know is that there really is little to no quality control. So we have to take whatever is given to us with a grain of salt in terms of the purity of the compound, the strength, possible adulterants, etc. This is still sort of a nascent industry. There might be some self-regulatory organizations that are doing some quality control, but bottom line, we really don't know what is in any of these compounds.
Okay. There's gummies, right? And you can smoke it. And what other methods of delivery are there?
So in general, when people use cannabis products, they could either smoke or vape. That's the inhalation. And that way it has a very quick bioavailability. It gets to the central nervous system almost immediately. So very quick onset of action and relatively quick offset of action too. The other ways people use it are through edibles, and so that way it's oral ingestion. It usually takes about 1 to 2 hours to be fully absorbed. The onset of action is a little delayed. This can sometimes throw people off where they have edibles, they don't have any effect, so they might overdo it. So that could potentially be a problem with the oral ingestion. The other ways, which are mostly theoretical, most people don't use it that way, are either transdermal preparations or through mucosal preparations.
Oh, really? Okay. I didn't realize that.
Yeah, these are available But most people tend to either inhale in the form of smoked cannabis or vaped cannabis, or use edible products.
And so edibles are like gummies and brownies and cookies and that sort of thing?
Pretty much anything, yeah, that you eat which has a phytocannabinoid in it.
Okay. And so then the thing that I kind of struggle with is that it's Schedule 1, right, by the FDA?
Yes, so the DEA is the organization that sort of schedules substances.
Okay.
Schedule 1, which is where cannabis is their is the category where they say it has the highest risk of abuse, dependence, and has no medical value. So cannabis, yes, is Schedule 1 as per the DEA.
Okay. So then if there is an accepted use down the road, then that would either cause it to be changed or it would need to be changed.
It would, and it
Okay.
has happened with CBD,
Okay.
which is currently available as Epidiolex, which is an FDA approved agent that people use for really serious intractable seizures, and that has now been categorized as Schedule 4. There is some talk that potentially it could be moved, cannabis could be moved to a category 3, which would give it more medical uh, use, but
Okay.
that has not happened yet.
Okay. So you mentioned the one for seizures. What other THC-based medications have been approved?
So the one for seizures is a CBD based
Oh, CBD
medication.
based. Okay.
Yes. And the THC based medications, we have a couple. So there is dronabinol, which is a synthetic THC analog, and the other one is nabilone. Both of these are mostly used for chemotherapy induced nausea and vomiting. And dronabinol also has an indication for AIDS related wasting. So
Mm.
these are the two commercially available THC analogs.
I feel like we're having more conversations about cannabis in sleep clinic.
I agree. I don't think I have a clinic day where somebody's not telling me about their gummies or other products that they're using to help with sleep.
Right. And I don't know whether it's just sort of a biased sample, but I feel like a lot of people use it for sleep. So yes, recreationally, but in order to initiate, maintain sleep.
Yeah, and so cannabis has the distinction of being the most abused or used illicit drug.
Mm.
And depending on what data we look at, it's anywhere from about 35 million to 50 million US adults use it in the last 1 month to 12 months. So a large number, about
Wow.
20%. So when surveys have asked people what is the most common reason they're using cannabis products for medical reasons, most people have said it's either to help with chronic pain, anxiety, or sleep. And sleep is really up there in terms of the indications that people claim to use cannabis products for.
Yeah, it's and so I didn't realize it was that high, first of all. That seems like a really high number of people that have used it in the last month.
Yeah, like I said, it has
Uh,
that distinction.
yeah, I didn't realize that. So then is there objective data? I mean, have we studied this for sleep?
We have to a degree. I think the skeptics can always say that we have really not done a great job in looking at its therapeutic uses.
Okay.
It has, I agree, been hamstrung a little because of the DEA classification as Schedule 1. So it's really hard to conduct meaningful research on cannabis products. There are a lot of hoops to jump through. But that said, I think at this point we have a reasonably large evidence base to to inform us one way or the other about its impact on sleep.
So what does the data show?
So the more recent systematic reviews that have looked at cannabis products and its impact on sleep architecture have really been mixed. I think the sort of clear signal seems to be when people use cannabis products, especially higher doses, there is a reduction in REM sleep. So REM
Mm.
latency tends to increase and the amount of REM seems to go down. There is conflicting data on what ends up happening with slow wave sleep. And we have some evidence to suggest that when people stop using cannabis after at least a reasonably long, steady period of using it, there seems to be a rebound in REM. So, that we know from a sleep architecture standpoint as to what it potentially does.
So, a few years ago at the sleep meeting, we attended a lecture by a sort of a basic scientist, and she talked about REM suppression with cannabis, and I didn't realize that then. And so then, of course, after I've learned this new piece of information, I'm thinking about it, and I'm thinking about, well, how does that impact MSLT, right? And do we treat it like we would any other REM suppressant? And how should we be thinking about it in that context?
I think we should be thinking about it in along those lines for sure. There again is very little data in terms of nightly consumption of cannabis and what it can potentially do to mean sleep latencies or sleep onset REM episodes. We can extrapolate from the data showing that if you take it away quickly, it can lead to REM rebound. There are at least one, maybe two studies showing that subjectively people note feeling sleepy during the day, so it
Okay.
can reduce the mean sleep latency, and potentially objectively can do that as well. So, in general, my clinical practice when I'm evaluating people for excessive daytime sleepiness has been to get them to stop using cannabis products at least 1 to 4 weeks prior to going through with the testing, because that's how long it takes to clear out of people's systems.
Oh, so like a month.
A
Yeah.
month, yeah. Especially if they are regular heavy users, it's going to take a month. For occasional recreational users, 1 week should be sufficient.
And does it matter how they use it?
In theory, it should not.
Okay. Okay. Because where my brain goes is the sleepy adolescent.
Right, yeah. And especially there, you really want to eliminate cannabis as a potential confounder when you're testing and trying to find reasons for their sleepiness.
Do you get a lot of pushback when you ask them to stop?
We do. A lot of times it's sort of how you pitch why you're getting them to stop, which is the approach I generally end up taking is that we want valid results. With this on board, we really can't tell if this is cannabis related or if there is an underlying condition. And in general, if people want to go back to recreational use or start using after the testing is done, they make that choice.
Mm. So let's go back to what the data, you talked about the difference in sleep architecture. Did they also look at sort of insomnia types of endpoints like sleep onset latency or wake after sleep onset? Did they look at any of that in that data?
There have been a lot of studies, more so recently, specifically looking at cannabis products in people who have sleep disturbances or a diagnosis of chronic insomnia disorder.
Mm.
So these were initially open label trials, and for the most part, they were actually inconclusive, negative, or in some cases, even showed maybe an increase in sleep disruption, depending on how you categorize that. There have been a couple of more recent randomized control trials in patients with chronic insomnia disorder. A couple of these have come out of Australia. These were very small studies, short duration, roughly 2 weeks. One of them was slightly positive, the other was not positive and didn't show any deterioration. But my concern with both of these studies is that they employed a crossover design.
Okay.
So they had people switch back and forth from cannabis to placebo,
Ah.
placebo to cannabis. And as we will talk a little later, as people stop using cannabis, it can cause sleep disruption. So at this point, I would claim that it is unclear as to whether cannabis actually helps or there is deterioration after 1 week of use. And that is actually what we are seeing in some of those positive trials.
Oh, that's really interesting because I think, we all have our population of patients who do utilize cannabis for sleep. And, and I think sometimes we have to adopt, at least with our clinic, I have a lady who's elderly and she has like a pot cookie before she goes to bed and she sleeps well and she uses her CPAP. And, it's really hard for me to argue with that.
Yeah, I guess I would take the same approach too. If it's not causing any major issues,
Mm.
they find that they're sleeping well, they really have no other complaints. We still talk about possible risks, and in this case, the main risk is regular use can lead to cannabis dependence. But
Mm.
outside of that, people make an informed decision about whether they keep going versus not.
So you mentioned open label crossover design trial. Have there been any sort of placebo-controlled, double-blind randomized trials with this?
Yeah, the last two trials that I talked about, the Australian ones, were actually randomized controlled
Oh, they were.
placebo trials. Yeah.
Oh, they were. Ah, interesting. So it sounds like maybe we're getting a little bit more sophisticated in terms of our research.
We are, again, small trials. So I think
Mm.
we need larger trials before we can conclusively say one way or the other.
So let's take a short break, and when we come back, we'll talk more about cannabis and its impact on sleep. You're listening to Talking Sleep from the American Academy of Sleep Medicine.
Dive deeper into the future of sleep apnea therapy with the Apnea Sleep Care program. Once we receive the PAP referral, our team springs into action, offering patients a seamless transition into therapy. Patients start by selecting how they want to begin their sleep journey: in-person care, virtual care, or self-directed care. With ongoing therapy support, including coaching, digital resources, and video assistance, we're committed to ensuring every patient's success. We stay connected with our patients with live calls, texts, emails, and IVR, all designed to make adherence a breeze. And with our supply schedule program, replacements are delivered like clockwork. Experience the difference of an enhanced sleep therapy program with Apnea Healthcare. Discover more about our innovative sleep program online today at apnea.com.
Welcome back to Talking Sleep. We're talking with Dr. Bhanu Kolla about cannabis and sleep. So, like you, I live in Minnesota, where medical marijuana was approved for the treatment of obstructive sleep apnea a few years ago. Is this something we should be doing?
The easy answer is no. This, I think, was based off of one trial, the PACE trial, where dronabinol, the compound we talked about, which is a synthetic THC analog, was tested in patients who had moderate obstructive sleep apnea. The study design here, too, I think, bears some sort of unpacking, because it was positive, but when you look at the raw numbers, the dronabinol group, the AHI decreased by about 2 to 4. So all of us sleep clinicians will recognize that is unlikely to be clinically helpful or even meaningful. The statistical significance in this trial was mostly because the placebo group, the AHI went up. So the difference really looked statistically significant, but we don't know if that was just a function of the placebo group doing worse after that time interval.
Oh, that's interesting. Okay. And then shortly after that, I think within the next year, the ASM released a position statement on the use of cannabis.
Mm-hmm. Yeah. The other concern with the cannabis products, so first off, we have many valid, effective treatment options for sleep apnea, CPAP and CPAP alternates, and really we want to start our patients there. But with cannabis products, our concern is also that they can lead to weight gain, which can potentially worsen sleep apnea. We know that sleep apnea increases the risk of daytime sleepiness, motor vehicle crashes. Cannabis also does that. It increases daytime sleepiness, also increases the risk of motor vehicle crashes. So, for all these reasons, the AASM has said that this is really not a viable treatment option, and I completely agree with that position.
So, what about for something other than insomnia or sleep apnea? What about like RLS?
So there have been some case series published which have shown that some patients who have used cannabis products for restless legs symptoms have shown improvements and have been able to discontinue some medication. Again, I'm sort of waiting and holding judgment till we get good quality, large randomized control trials before we can say conclusively one way or the other. We don't have that right now, so I don't think there too cannabis or cannabis products are really a viable treatment option.
What about other sleep disorders? I think I read something about maybe RBD.
So RPD again is an interesting story in that there were initial case reports and case series which showed that patients reported benefit with cannabis products in terms of frequency and intensity of RBD symptoms. There has actually been one randomized control trial which was published in 2021, which was negative in that there was no difference between placebo or cannabis products. So again, there too, I don't think we have any clear indication to use cannabis products.
So I heard you earlier talk about, recreational marijuana and medical marijuana. Do people kind of do one or the other, or is it more mixed?
In most cases, it is mixed. So people who are using for medical reasons, depending on the survey, 70 to 80% also admit to recreational use. So there is a substantial overlap. Wearing my addiction hat, we are in addictions actually a little more concerned about medical use, especially in cases where there is no clear indication or no clear evidence of benefit, because one of the major risk factors for developing a cannabis use disorder or dependence to cannabis is frequency of use, and medical users are much more frequent or daily users as compared to recreational users.
Oh, I never considered that. That makes sense. Okay. And then do you find that there's more resistance to coming off of it if they've been provided it for medical reasons?
There is, and there is resistance even with recreational use, so it's not unique to medical use.
Okay.
Especially in the context of sleep problems, I think one sort of conundrum we keep running into is that when people stop using cannabis, especially after a duration of regular use, part of withdrawal from cannabis involves sleep disturbance. So it's actually cited as one of the most common withdrawal symptoms that people experience, and it could be anywhere from 66 to about 75, 78% of people withdrawing will report sleep disturbance. And that could be difficulty falling asleep, staying asleep, waking up earlier, having a lot of dreams that are disruptive to their sleep. So, in general, what ends up happening is patients feel I was using cannabis, I was sleeping better, I have stopped now, I'm sleeping worse, therefore, maybe it was treating my sleep problems. And it's one of the most common reasons people relapse or go back to using cannabis. That is, their poor sleep sort of leads them back to ongoing use.
Well, and that's a perfect setup, isn't it? I mean, it's very similar to hypnotics, right? And so then I bet there's a lot of education, and it must be harder, though, because of the longer half-life.
It is. So most studies have shown that it's about 2 to 4 weeks, and it could be as long as, say, 12 weeks before sleep disturbances settle down.
Wow.
So a lot of it is reassurance, education, hand-holding, if necessary, treating short-term sleep disturbances with a hypnotic for that length of time, with the idea that in that 4 to 12 week time frame, things settle down and you can get them off the hypnotic.
Okay, I kind of wondered. So then you're offering them some other, hypnotic with a plan to then have an exit strategy.
Exactly.
Okay. Is there any one that is better than others?
So, as usual, you start with melatonin, which I think has very low risk. If it pays off, great. I'm going to talk about the other medication that ASAM doesn't like, trazodone. In my psychiatry practice, we use trazodone. We've used it for decades. It works fine. So that's the other medication. There is actually a recent trial which used extended release zolpidem products, and they showed that actually was quite helpful in reducing sleep disturbances and also reduced the risk of people returning to cannabis use too. So that's a potential treatment option as well. Yeah.
I was surprised to hear you say melatonin first.
I love melatonin. I think if I can get by without having to prescribe medication, if it works, great, you're home and dry. If it doesn't, then you can move on up the ladder with other hypnotics.
So when you use trazodone, do you push the dose?
So usually it's 50 milligrams. 50 to 150 is the dose that I usually go for. Yeah.
Okay. But you think extended release zolpidem is kind of the one?
That's the one that has the evidence right now. Clinically, again, it's a little fraught in that if you have somebody who has a cannabis use disorder, you want to be careful. The risk is very low, but still exists for people to have what we call cross addiction, so a different compound that they start using and have trouble giving up.
I wondered about that. I think I can remember maybe 2 or 3 people that had this sort of addiction to Ambien. And it is hard.
It is. Again, it's very rare, but it's not like it doesn't exist. It does happen.
So then you have to put them on something else.
Hmm.
Okay.
Or very slow taper while they work on other behavioral strategies. That can also work.
So I can't get over the 20% number in my head of 20% of people are using cannabis. So what side effects, and I'm thinking more sleep-related side effects, should we be aware of in our patients?
So occasional recreational use possibly doesn't lead to too much sleep disturbance. It can maybe shorten the sleep onset latency a little bit. It's usually when people are using regularly larger quantities, that's where we start seeing some sleep disruption, especially middle of the night awakenings and some of the sleep architecture changes that we talked about.
What's considered a larger quantity?
So dosing is actually very hard, especially for inhaled or vaped products.
Okay.
Most THC compounds seem to be about 5 milligrams. Usually when you're going beyond 10 milligrams, that starts becoming a problem. And naive users, usually when they get to 15 or 20 milligrams, that's where the risk of psychotic symptoms really increases.
Oh my gosh. Okay. And that's edibles then, right? 5 milligrams, 10 milligrams?
Edibles, but it could be other compounds too. So if they're vaping very high potency THC products or smoking large quantities, and we're talking of relatively naive users when they overdo it.
Okay. So forgive me because I have zero experience. Is the dosage the same?
There is really no good way to tell the dosage for any compound because again, these are not regulated, so you have no idea what you're getting. And especially for smoked or vaped products, it's much harder. For the edibles, to a degree, people can tell the dosage that they're getting.
And that's assuming it's some sort of like gummy as opposed to somebody making a batch of brownies.
Exactly.
Okay. Okay. This is helpful. Thank you. Whenever people fill out that questionnaire and they talk about how much marijuana they use, sometimes they will use some sort of unit that that's new to me. So one person said like 2 to 3 bowls a night. And the person I had to ask, I was like, okay, what does this mean? Like, is this a lot? Is this a little? I don't really understand. Turns out it's a lot.
It is.
But okay, so that's helpful. Do you think that cannabis is safer than prescription sleep aids?
At this point, no. So prescription sleep aids, hypnotics are not without their downsides, but these are pharmacological grade compounds that have been studied. We have years of experience using them. We have safety data on all of those. All medications come with risks and with benefits, and when the benefits outweigh the risks, we use them, and that's the case for the hypnotic medication. With cannabis at this point, we really have very little efficacy data. We have some concerns about safety that we talked about, and we really have no long-term data in terms of how they might continue to impact sleep and what might happen. So for all those reasons, I don't think that they're better than prescription hypnotic.
Okay, that's helpful because that's sort of that's what I hear, right? It's natural, therefore it's safer. I don't want to do sleep aid, but I'm willing to, have an edible.
Yeah.
So, okay, that's helpful. So any final thoughts?
This is an interesting space. It's going to continue to evolve, and I think we need to sort of remain agnostic but also skeptical of some of the claims. And as the data comes in, the database develops, I think we might be in a better place to sort of understand the role of cannabis in treating any of the sleep conditions. But based on what we have right now, and I would claim that we have a reasonable amount right now, there really is no convincing evidence that they're particularly helpful for any sleep condition.
But it sounds like you're receptive to the idea that there may be use down the road.
Potentially. Again, I think if the data changes, we need to be open to changing our mind.
Well, thank you for joining us today and helping us to better understand the current data behind cannabis and its impact on sleep and sleep disorders. I'm sure this is an area we will revisit as more states adopt the legalization of marijuana and as we develop more data and guidance on its use.
Thanks so much for having me.
Thanks for listening to Talking Sleep, brought to you by the American Academy of Sleep Medicine. For more podcast episodes, please visit our website at aasm.org. You can also subscribe through your favorite podcast service. And if you enjoyed this episode, please take a moment to leave a rating or review. For more feedback or suggestions, email us at podcast@aasm.org. I hope you'll join us again for more Talking Sleep. Until next time, this is Seema Khosla, encouraging you to sleep well so you can live well.